Medical Shockwave Institute community, or I Love Shockwave community. I have a special guest today with us, Stefan Bundrock. He is our only and main instructor for men's health in shockwave therapy. So he's gonna share his personal experience with us today. So, Stefan, uh, who are you professionally?
Well, first of all, thanks, Uran, for being on the show. It's a great honor for me, and hello, everybody. I am a urologist, and in my past, people tend to forget that I'm a urologist because I'm different things. So mainly, I'm working as a urologist, but I started off as a banker, as a matter of fact. Before I went into medicine, I didn't like it, so that was back then. And then at the same time with studying medicine, I studied Scandinavian languages. So I also have a PhD in Scandinavian languages. This is why it's doctor, because I did 2 theses about this. And then I would like it from the very beginning. I was in medicine. Everybody would say, well, this guy is some arts student. We don't know what he's doing here. And then in Scandinavian languages, they would say, well, what's this doctor doing here? We don't really know. And this just continued throughout my professional career. So even my colleagues are sometimes kind of confused. Who is this guy? I was working in urological rehab for a couple of years, and this added to the confusion. But I'm a totally normal urologist. I spent my days in general surgery. I operated. I did oncology. I'm coming from the oncology corner. I was very much involved in oncology throughout most of my career, and traveling through many countries, mainly the Nordic countries. So I was educated in Iceland, Sweden, and the last years I worked in Norway before I returned to Germany. Then I went into rehab. And eventually I ended up in Göttingen, which is a small university town in the middle of Germany. Here I have opened my own practice, and this was in 2017. And from day one, I decided I will invest into ESWT because I thought that was just a great technology. And here I am.
Yes, yeah. It's interesting because I can easily call you your a hidden gem of shockwave therapy world. You go to the International Society for Medical Shockwave Treatments. You see the same people, the same practitioners. So that's what I went, in mind in Amsterdam this year to meet somebody in urology. I come there, I didn't meet you there, I didn't see you there, and then I saw one of your interviews on LinkedIn, and I said, "Oh my God, who's this?" So, and then it dawned on me, it's like he is a hidden gem of shockwave therapy in urology.
Well,
Wow, wow.
thanks.
So, so how did you find out about shockwave, or like, because this is personal experience, and probably this is going to help other practitioners. It's going to help me even understand. So many practitioners hesitate to invest on the tool and
Mm.
get the shockwave because they don't know. Like, how did you make the decision? How did you find out? What made you to actually invest on this tool?
I was exposed to a machine at a congress, and it was of the one of the congresses of the European Association of Urology in Paris. I don't really know which one that was. I think it must have been around 2012. I don't really recall, but at a very early point in time.
Okay.
I just briefly looked at the machine and decided that that was nothing for me. But that changed because in around that time, I started an education in sexual medicine. So I told you I'm a urologist, but being chief of a big rehabilitation hospital in urology in Germany, was confronted with thousands of patients with prostate cancer after radical prostatectomy. So we had around 3,000 patients at least per year attending to our hospital, which means that a lot of those guys, they were really suffering from sexual side effects from the treatment of prostate cancer. Not all of them, but I found out around 10% were really suffering. And at that time, I thought, well, it couldn't be the end of everything that we just say, well, be content that you survived. So knowing that these guys would live for several decades, I thought, well, somebody has to do something. And this is what got me into sexual medicine. And this more or less happened at the same time. Sexual medicine, the path that I took was more or less sexology. So I learned sex therapy, and it's couples therapy at the Charité in Berlin, which is one of the institutions which is large in this, because, you know, sexual medicine or sexology was founded at this very institution of Magnus Hirschfeld. And he was a doctor researcher at the end of the 19th century. So eventually I returned to this very fine facility and was taught how to do sex therapy, this very special kind of therapy. And then eventually I got involved into ESSM, European Society of Sexual Medicine, ISSM. I became a member, and then I took these educations or the exams. So I became a fellow of the European Board of Sexual Medicine. And this opened up another window for me, because being from talking to people, I was exposed to also technical aspects about what kind of medicines and what kind of therapies, physical therapy, what could be done. And I started to combine that. And at this time, I more and more, I read a lot. So I read more about shockwaves. And when I decided to open my practice, and that was in 2016, I went to one of the large fairs in Germany, which is called the Medica. Medica is really big. Some of you may know it, and it's in Düsseldorf. And there was one of the companies selling shockwave machines. So I was very interested, and at that day I decided I will buy it, because all of what I've read about shockwaves and how I wanted to tackle this, I thought, well, this must be it. Even though we don't have much evidence, but I just told myself, good, just go for it, just buy it. And this is how I ended up with
One
shockwaves.
feeling. Yes, yeah. And how was you know, you got the device, you start using it, and how did you find it in practice? How was working as a tool?
The problem is that many patients, they don't know it, or the
Yeah.
patients who know about shockwaves, they have been treated with it for orthopedic indications, like for shoulder pain or Achilles pain, stuff like that. And some of them said, well, we know this, and it has helped me in other areas. But you know, I'm not a good salesman. That's a very big problem in my life. So I'm a kind of anti-salesman. So whenever I try to sell something to people, they don't want it, and vice versa. So when I don't want to sell anything, they want to have it. And with the new therapies, I was trying to get patients, but it's very hard to sell this kind of treatment where you don't have much evidence if you're not a salesman. So how do you get people to buy that? And that was a very big problem in the beginning, until I finally got some patients and I got more experienced, and then I could more confidently tell people about the effects that I've seen, and that made it much easier.
Yeah. You
And
know, sorry, I wanted to add something here, and I probably we're gonna turn this your experience, but also we're gonna
mm,
help other practitioners, because as a healthcare practitioners, we are very good on helping people. We are
mhm,
designed for that. We want to help from the heart, but we consider and we look ourselves that we are actually not good to sell. And it's very true. Like I see that even from a business perspective, where a lot of healthcare practitioners actually fail on the business aspect, on the sale aspect. And the main reason being is that we always strive or put the energy to give the maximum possible to the patient, to the client. So our confidence level, it's lower when we start with something, new. So it's not about, the techniques of sales. It's about education, and it's about our confidence of presenting that to to the client. Because you just said, even yourself, with experience and with more confidence, then everything start rolling better. And this is something that we're even trying to fill, both of us, right? That now with our experience, we're trying to actually tell new practitioners with the training and stuff that, hey, if you get the device, if you get the tool, and start with with it, you gain that confidence faster, and then everything else happens faster.
Yes,
So
and
yeah.
I think what helped me was also I'm not treating everybody, so I'm getting more and more restrictive the more experienced I get, and the selection process has changed very much. So, like in the beginning, I was trying to get patients. Now I'm trying to get better success at what I'm doing. So I'm trying to select my patients where I know they have a chance to improve through Shockwave. So there are some, I think the patients who profit most, maybe they are beyond 40 and maybe up to 70, maybe a little less. And sometimes I have patients coming in who are 75. So we have to calculate with that, and knowing that those patients, they are 75 years old and their sexual organs are 75 years old. And
Yes.
it's very difficult to rejuvenate something that is hard to rejuvenate. Um,
Yes.
and in these patients, if they want to do it, I really counsel them on maybe we shouldn't do it, because there's a lot of money involved, without doubt.
Yeah.
And the prognosis, I'm afraid, is not very good. But if I go for something in those patients, I will like combine everything I have,
Yeah.
just to try to do everything. So not just shockwaves, but also PRP and EMTT in a combination to try to get something going here.
Yeah. So Stefan, are you talking, is this specifically for erectile dysfunction between 40 to 75, or is it more for Peyronie's, or just in general
No, it's more for erectile dysfunction.
erectile
I
dysfunction?
have
Okay.
3 areas where I use shockwaves right now, which is
Yeah.
the main thing. The main reason why I bought this is erectile dysfunction.
Yeah.
But where I see the best results is pelvic pain. I just have to say that.
Okay.
Um, we had a meeting the other day, remember, where I was presenting my data,
Yeah.
and I was telling the audience, like, if you're looking for a miracle, go for pelvic pain and shockwaves.
Yeah.
If you're looking for good to very good results, go for ED. And there, I think there is a place for shockwaves in Peyronie's disease, but it remains to be defined what kind of place this is. So I was treating a patient with Peyronie's disease today. I've been treating him for 3 months in a combined treatment approach, not only shockwaves. But I think that in Peyronie's disease, shockwaves don't do the trick if you're not doing some kind of traction.
Okay.
But now he's telling me today that is slightly improving. And in these cases, I always ask about the partner. So I asked him, "What's your partner saying? Are you improving?" And he said no. So we'll have to wait and see what's happening. But what I saw today, this is why I'm bringing this up, is the plaque. If it's not calcified, so if you can't see it upon ultrasound, it really gets soft. So I start with a really definable plaque in the penile shaft.
Yes.
And after I'm done, like halfway through, I can't really feel it anymore because it's so soft. And this is something that stays for 3 to 4 days, and then it hardens again. And the reason why I'm using shockwaves is because of this effect. So hope that doing traction in this state will enable to get something going with the curve, with the curvature.
Yeah. Yeah.
And I have some patients where this worked, but I wouldn't be able to tell you whether this worked just because of the shock waves or if it would work with traction anyway. So I'm not a scientific institution, so I'm interested in results and not in pulling things apart and see what really did the trick.
Yeah. Yeah. Yeah.
But
Wow.
this is how I'm using Shockwave. So for pelvic pain, I'm now at, I would say, yeah, it's maybe 50, 70%, 60% success rate.
Okay.
And I was very lucky because when I started with pelvic pain, it was during the pandemic.
Okay.
And all of a sudden, there was a big wave of patients just flooding into my practice with pelvic pain.
Yes. Yes.
That was, I don't know, did you see that too in Canada?
Yes, yeah, in rehab, and part of it is because people were sitting a lot more. They weren't as active, and that was I saw a lot of lower back issues, which are
Mm-hmm.
related to the pelvic pain, and then a lot of knee issues, a lot of hip issues. So that's what I saw from a musculoskeletal perspective.
Mm-hmm.
Yeah.
And I think I must have seen the same. So maybe all around the world, people suddenly saw these pain patients.
Yes.
And I was very lucky that I had heard about the effects of shock waves on pelvic pain. And one of my first patients was a good friend of mine, and he was incredibly in pain, so he couldn't sit on a chair.
Wow.
And I told him, you have to be the first patient, because up to then, nobody wanted to be the number one. And it was a miracle cure. After 6 sessions, like 6 weekly sessions, he was pain-free. And he had been to a urologist in his hometown, telling him that he was suffering from chronic prostatitis. Then, because of this wave that came into my office, I included them all. And I was very lucky that the first patients, I cured them all. And that set the tone for treating pelvic pain with shock waves.
Yeah.
And then after a short while, it happened that I couldn't help one of my patients, and then now I'm down to, I would say, 60%. So I'm trying to pre-diagnose my patients to make sure that they have a chance of being helped. And in some patients, it's just incredible. And they have been to several doctors. Nobody knows what this is. They get the diagnosis of chronic prostatitis. Due to my experience with shockwaves, I really have to start doubting this diagnosis, chronic non-bacterial prostatitis. I'm not quite sure what this is anymore. I think it's all muscle, or
Yeah.
lots
Yeah.
of this is muscle.
Yeah.
You're seeing them as well, right?
Yes, yeah. So this is actually my follow-up question in this topic. So from a urology or from your perspective, so when you say chronic pelvic pain syndrome, do your clients, do your patients come in complaining about urology, symptomatic concerns, or is it just the pain that they come in? So do they have any bladder issue? Do they have any, like they think they have a prostate issue or?
As a matter of fact, all of it. It's a mixed picture.
Yeah.
If you've seen lots of patients, there's a pattern emerging who might be a candidate for suffering. So it starts with pain. So we have all these pain syndromes. So what we call chronic non-bacterial prostatitis, chronic testicular pain, which is incredibly common in men.
Yeah.
Then urethral pain, bladder pain, urgency, post-micturition dribble, pain with ejaculation. These are very suggestive of pelvic pain issues.
Wow. Yeah. Yeah.
And we are not trained as doctors or as urologists, at least not in
Yes.
this part of the world. We are not trained to recognize this. And I think we don't know about this. So you guys, you are the physiotherapists, you know about
Exactly.
this,
Yes.
but
Yes.
doctors as a rule don't.
Yeah.
That's too bad.
Yes. Yes. Yeah. Very, very true. It's see There are two things, and always it's like once you diagnose, once the assessment is good, once you figure out the patterns, then when it comes to treatment, then you decide on the tool. So even in our case, even with musculoskeletal conditions, for instance, I pay a lot of time to figure out where the problem is coming from, because
Mm-hmm.
typically when people end up at my practice is because they have already tried, classic physio, they tried the exercise,
Mm-hmm.
electrotherapies, dry needling, everything. They tried cortisone shots, they tried medication, nothing has, solved the problem. So when they come in, I have to put the pattern together. Like, how
Mm-hmm.
did they start it? Listen, probably takes, sometimes an hour to listen to those clients. And then I use only Shockwave actually just as a monotherapy. Um, and even with good assessment, when I combine it with Shockwave, I always get very good results in
Mm-hmm.
pretty much most of the musculoskeletal conditions.
Mm-hmm.
But it has to do a lot with assessment. And then what Shockwave gives me, it gives me the ability to reach deep enough. So
Mm-hmm.
I don't have any other modality that can reach, with a focal Shockwave, 5 inches deep, 12.5 centimeters deep, without hurting any cell. It's like
Mm-hmm.
without causing any side effects.
Mm-hmm.
So it physically releases the tissue, the structure, and then it stimulates regeneration. So yes,
Mm-hmm.
I have cases where people during the treatment phase, what I call it the treatment phase, they get symptomatic relief or the symptoms change. But there are some cases where the symptoms don't change, but then later on, 3 months later, they come
Mm-hmm.
back and say, it's like, wow, whatever you did changed my
Mm-hmm.
life.
Mm-hmm.
So that's where I kind of see that, okay, even though the diagnosis was in place, we did the shockwave treatment properly, treated all the areas, there was a need for the regeneration of those tissues, and therefore
Mm-hmm.
until that happened, symptoms don't change. So
Mm-hmm.
yeah.
Um, what it's very funny, but what helped me the most was golf.
Yes.
Helped me a lot because um, I'm like I said, I'm a urologist, but I'm very interested in everything. So I always say you can talk to me about everything but with the exception of dancing. I'm not interested in
Yeah.
dancing,
Okay.
but for the rest, I'm very interested. So I also have a qualification in sports medicine. And since I'm playing golf and I was injured myself a couple of times, I thought, well, I might go into golf medicine. And then in the States, there is this institution called TPI. The title is Performance Institute. And I did a lot of these classes to become a medical golf professional or for golfers. And that really opened my eyes because you go through how the body functions and you go through movement patterns. So when you're a doctor or you're orthopedics, I also did lots of orthopedics when I was a resident because I was on when I was on call, I just had to do this. So I have nailed hips and I've broken arms and all this stuff. I've seen it all. But as a rule, you go right for the problem.
Yeah.
But in this approach that I learned, which comes from functional movement, you think of the body as moving in patterns, and you try to differentiate between patterns. And even if it's not hurting, and you see there's a pattern not functioning, it may hurt another place. And this is something that was very new to me, and it helps me a lot when I assess the pelvic floor. And I remember I had one patient this a couple of years ago. He was a young man, and obviously he had a pelvic floor dysfunction, and he had to been to an orthopedist and had been diagnosed. And they didn't find anything, so he came to me with pain, and I treated him with shockwaves. And with shockwaves, I always try to find trigger points. And I think that's pretty much the magic of it. Sometimes you don't find trigger points, it helps anyway. But if you find trigger points, then you really get effects. And this is my experience. Um, Actually, it's 3 days after the second treatment, if you do weekly treatments, then it's very reliable. They tell you, okay, at this day it started to loosen up. 10 days, it's around 10 days. And this guy, when I was trying to find trigger points, I got the impression that something with his hips was wrong. So eventually I told him, I think we have to check your hips. And did they check on your hips? And he didn't really know because he had back pain too. And from TPI, I remembered that 60% of people with lower back pain are misdiagnosed for lower back pain and not for the hip wasn't identified as the real cause of the problem. So I got him to another orthopedist and they did an MRI, and then it came out that he had a hip dysplasia, which he was born with and nobody had diagnosed. And that was his problem. So he had to have an operation and then he was fine. So it really helps to think, even if you do shockwave therapy, and always question yourself, am I doing the right thing? And I'm always asking my patients during therapy, do you think this is working? Even though I know that, as you said, after 3 months, we really can say if it worked or not. But I kind of demand from my treatments that after 3-4 sessions, if it's pelvic pain, you have to see some kind of result. If you don't, I tell my patients, well, maybe we work a little bit, wait a little bit, and then if it helps, we can, at any time, we can restart.
Yes, yeah, exactly. See, and this is something, Stefan, that in life there's never a coincidence. There's a synchronicity. And even when I found out about you, I was looking
Mm-hmm.
for our platform, who can be the practitioner that truly looks at human bodies in one unit. Because in school, we all learned, when you learn anatomy, when you learn the physiology, you learn everything, by names.
Mm-hmm.
And they named the structures, our muscles and organs, so we can actually learn and communicate and know where things are. But when we stop and think, our body function as a one unit. There's no names inside, so it's a
Mm-hmm.
one single system. And even for men's health, or pelvic health in this case, um, when I saw what you put together on the training, you emphasize like half of the training, it's actually how to diagnose, how to differentiate,
Mm-hmm.
how to tell that
Mm-hmm.
this is where it is and what to do, and then half of it, it's actually how to do it. So
Mm-hmm.
that's incredible. So thank you for that. My I wanted to clarify something, and this is gonna lead probably to a slightly different topic or completely different topic. I can see that. I want you to clarify to the audience what type of shockwave do you use? Because
Mm-hmm.
especially in North America, when you say shockwave, then that term, it's including shockwaves like radial pressure waves from Amazon, you
Mm-hmm.
know, radial shockwaves from distributors that are, their proper devices, and then the actual true shockwave. So, what type of
Mm-hmm.
shockwave do you use for men's health?
Mm-hmm. So I'm also talking to my patients about this, and I say I'm using shockwaves. Period. Because there's only one shockwave. There are not different types of shockwaves. There's only one. And a shockwave is an acoustic wave. It's not a sound. It's an acoustic type of wave with a very special curve and very special features. So a shockwave has a very short pressure spike, and this is so strong that it has a negative pressure, so to speak. So it's like it's flushing the cells, and then it's dragging the cells, and it's traveling much faster through any material, any matter, than sound. So it's not sound; it's a special kind of wave, and this wave can be brought about by different means. I'm using electromagnetic um, generator. There's a electrohydraulic generator. There's a piezoelectric generator, and these are, in terms of focal size and stuff, they differ quite a bit. But essentially, what's coming out is a shock wave.
Yes.
Then we have devices which you can buy on Amazon and on all these platforms, and which cost a couple of bucks. And what they do is they accelerate a projectile in a probe. So what's coming out is also some kind of acoustic wave, but it's more like a sound. So it's a ballistic wave, which behaves totally different than a shock wave. And this is a radial pressure wave. And radial pressure waves are not shock waves. As a matter of fact, shock waves were discovered during World War II. So they found injuries in a submarine crew caused by shock waves. At first, I didn't know what that was because you couldn't see it, and it was like, what kind of is going on here? What's happening? But then in the 50s, they found out about shock waves and they started to experiment with it. And then in the 70s, they finally found out that you could crush kidney stones with shock waves. And that was the start of a revolution in kidney stone treatment. And some of you may remember this bathtub, which is the Dornier device, which was the first one. You would be submerged in a bathtub in the water, and then it would aim on your kidneys and crush kidney stones with these shock waves. And these were real shock waves, the ones that we are using today as shock waves, but much more powerful than we are using them. And that wasn't radial pressure waves. So when we treat with radial pressure waves, they don't penetrate that deep into the tissues. They behave differently, and they have effects. So I think you're using also radial pressure waves, right? You have even courses on radial pressure waves on your website.
Yeah.
So they are effective for certain indications, but
Yes.
for the time being, we cannot be sure whether radial pressure waves are also equally effective for men's health as shock waves are.
Yeah.
And that's the problem. So I know about the mix-up because I'm on YouTube.
Yeah.
And I get all these questions about radial pressure waves, and people are mixing it up. And this is a problem because it's marketed by the name of shockwaves. And even if you go on the big websites of the big companies that are promoting radial pressure waves and they promote science, I've done that. So 95% of that science which is presented is from shock waves. It's not from radial pressure waves, and they're mixing it all up, which is a shame. So it's very confusing for people not really going into depth about this topic.
Stefan, it's like even this episode and this conversation that we are having together, I hope it shed light, to all these practitioners, if they're already using, radial pressure wave for men's health, or if they're just like looking to get started. We want to educate and tell the difference because personally, I'll tell you my personal story. So in 2016, I had a guy from States who found us, my training online because I used to do in-person training. We're starting that again now, but at that time in person. So he said, "Oh, I want to get training in shockwave therapy. I'm looking on this device for, erectile dysfunction, Peyronie's," and then he shows me the company name and the device, and I said, "Oh my God, this is radial pressure wave. How come they're using, radial pressure wave for men's health in Europe? I think that's not allowed, correct? Is there regulation or?"
No, as far as no, not that I know of.
Yeah, I never like going, to Germany or going to ISMST, to the International Society for Medical Shockwave Treatments. I've been going there since 2013, never heard. So that's why when I heard this, in States, I said, "Oh my God, this can only happen in United States." And main thing being, like no regulation, but how come this is even possible? Because they're taking the science of a completely different tool and they're actually selling and presenting completely different tool. And unfortunately, there are even distributors, like they're a medical distributor. They have the salespeople because the salesperson, their goal is just to sell the device and they don't really care what happens after that. And this is the sad reality because you have thousands and then thousands of devices used nowadays and practitioners have zero training. And then, I see people, even for MSK, coming saying it's like, "Oh, shockwave is very painful." I almost passed out.
Hmm.
You see, people bruised, like with a bruised shoulders. Like, how can you bruise a shoulder
Hmm.
with Shockwave? But it's like they're pressing physically with a handpiece. So
Hmm.
I think your job and journey and my job and journey is because of our experience
Hmm.
already in this field. Whatever we can provide, practitioners with help and saying, it's like, at least if you're in that phase of starting, it's consult us, like, read, tell the difference, and don't listen to the distributor and saying, it's like, because their goal is just to sell it. Whatever they
Hmm.
sell, that's their best device. And nowadays, information, it's free. Like, even look at this. This is our time,
Hmm.
that we're putting for those practitioners to kind of learn the difference. Um, Anyway, so I remember like tools, shockwave tools are important. Like I actually have personal experience with Radial. I have with focal electromagnetic from stores, and then I have another electrohydraulic device. It's called Flashwave. That brand does not exist anymore. So I combined three different tools
Hmm.
for MSK, because we are trying sometimes, to release the muscle and activate the muscle. In urology, I remember you used to use a different tool, and then you find it wasn't as effective in a way.
Mm,
Uh, did you have a different device like initially?
no, it was equally effective.
Oh, equally effective.
Yeah,
Okay,
yeah.
okay.
I'm a fan of electromagnetic.
Yes,
Just have to say
yes,
that. And I
yes, yes,
chose electromagnetic as my first and only method that I'm treating patients with, at least for the moment,
yeah,
because what really convinced me was when I was looking at those, because everybody has to know when you buy a machine like that, it's
yeah,
the costs don't end.
yes,
So you
yes,
have to
yes,
have the maintenance, and you have maintenance. You must
yes,
do the maintenance. My first machine broke down regularly after a year if I didn't do the
yes,
maintenance. So you really have to have the technician there for checking the machine once a year, and this is a lot of costs. And you have to change applicators. And depending on what kind of shockwave machine you use, you have to replace applicators now and then, and they are very expensive. And plus, that electromagnetic devices were the only ones which deliver from the first to the last shot the energy which is put on the machine. So you can be
yes,
sure when you put the machine on 0.25 millijoules per square millimeter, this is what is coming out of the applicator. Whereas in electrohydraulic or a piezoelectric, the applicators wear off. And even if they show you that there's a certain energy that's coming out, it's probably less. And you have to
yes,
replace the applicators now and then. And the first machine that came out, um, the device where most of the studies have been done with, you have to replace the applicator. I think after 150,000 shots,
oh
it's
wow,
very very soon, and they're very
yes,
expensive. And I thought, well, I want to give the energy which is on the applicator, not giving less, because then the outcome might be less. I don't know.
yeah, yeah,
On the other hand, what I think is good about electrohydraulic devices is that the size of the focus is larger, which makes it easier to treat sometimes. And even if you treat large areas like for pelvic pain or musculoskeletal stuff, it might be better to have a larger
yes,
focus, because with the machine that I'm having right now, it's a Storz Duolith. The focus is smaller, and I can really feel this, and I really have to adjust when I treat patients, because sometimes they have trigger points and they stay on a spot, and you really have to fine tune where to hit that spot.
yes,
It
yes,
was easier with the areas which I had before that. The focus was larger, but even then it was an electromagnetic device.
yes,
Um, so you have to balance your therapy. So as long as as it is shockwave, I don't
yes,
think it matters that much to just make your experience with the machine, and then you can try to discuss: is there a difference between shockwave machines? Nobody knows that for the time being.
Exactly.
Could be.
It's yes, yeah, yeah. Same experience here. Same experience here. I use electromagnetic, and even for orthopedic conditions, the focal point is kind of in
Mm.
between, and it's very precise. The maintenance cost it's actually lower. I have the flash wave,
Mhm.
and I think that it's the only one in the world that I can afford to run that machine because it only lasts 50,000 shocks,
Oh.
and it cost me about I think it's like 1,600 Canadian dollar to
Mhm.
do the revision. So it's almost like 3-4 cents per shock just
Mhm.
to run that machine. And on top of that, it's maintenance cost. Like sometimes they break, you have to ship them, the
Mhm.
downtime. So it is yeah, it is an expensive tool to run it.
Mhm.
But then when you look at, what it does for the client, truly makes a difference. And then it's worth it. Like I
Mhm.
built actually 3 clinics based on the Shockwave. And it dawned on me that one of my physiotherapists said, "You're the only one that I know that you turned the business from a I took it's like everything it's built from Shockwave. Like we're
Mhm.
known in Shockwave. I've done over 35,000 treatments personally just in musculoskeletal conditions.
Mhm.
And it's true. So when I look at even from a business perspective, it's worth investing because this is something that a lot of practitioners, are afraid, and it's a big concern for them,
Yeah,
thinking that
maybe,
it's just
but
another tool.
but
So yeah.
I think when I think I told you once when I have a couple of years that I will work, but
Yes.
the day I retire, and that's for sure, I'm going to sell everything in my office except my Shockwave device. I will keep it
I love it.
because I know that it works. And I've tried it myself, right? So I know that this is very effective stuff, and I wouldn't want to miss it. So I'm more or less treating the whole family with shockwaves, although I'm the only one who's tolerating it. So from my wife's side, they are very wimpy people.
Hey, my wife said this how do people allow you to do this to them? And then but I'm gonna add something into this.
Hmm.
Um there's a saying, I've heard this. I don't know where I heard, but I heard it's true, is when people say it's like, oh, don't get massages because then your body it's used to it and it craves more massages.
Hmm.
What what that means is that shockwave hurts, or I found from my personal experience, when the tissue is super tight. There's
Hmm.
a lot of scar tissues, adhesions. The tissue it's inflamed. So the more time you do the shockwave, the tissue improves. It absorbs
Yes.
the energy easier, so it actually becomes less pain. So I think a lot of people that find it very painful, in the beginning, is because they're so tight. They haven't done anything to the tissue.
Hmm.
So
It's my experience as well. So
yeah,
when you after 2 or 3 sessions, it doesn't hurt that much anymore, and
exactly.
it depends very much on where you're using it. So for men's health,
Yes.
when I'm using it on the penis, it doesn't hurt. There's just a
Yes.
small stinging maybe,
Yeah.
but the bone is covered with a very sensitive structure,
Yeah.
and when you hit that, that really hurts. And I had a golfer's elbow, and when I applied this, I endured the pain until I really got sick in my stomach because it was so painful.
Yes.
And this can happen. So I always try to adjust the levels that I'm treating my patients with, because I know uh, s- all of a sudden you can be very sick because of the pain.
Yes. Yeah. Yeah. I've seen actually, it's interesting. I've seen the protocols of these companies that use radial pressure wave for men's health. So
Hmm.
what they're doing is they're using lidocaine to numb, the penis because the radial it's
Hmm.
painful, and then
Hmm.
they're using like the C15 applicator, which is just from the nature that applicator. It's a ceramic applicator
Hmm.
it has a little bit more, it has very superficial impact on the skin, like it's painful. And
Hmm.
then they're going and use like 3 bar pressure. So when I saw that, it's like, oh my god, how this is possible? Like, how can the penis still stay in place, you know?
The penis is very insensitive to any kind of force. This is
Yes.
my experience. As long as it is flaccid,
Okay.
so you can do lots of stuff to a flaccid penis without it taking any damage. But as soon as there is the slightest kind of erection that's coming into the penis, then you have to be very careful what you're doing.
Yes.
The penis then is easily hurt. I think this is fascinating because the penis, we don't have a bone inside our penis. So some mammals have a bone, like dogs have a bone inside their penis.
Okay.
We don't. But we have something that's much more elaborated, which is called the fibroskeleton of the penis. We have a structure that's surrounding the um, erectile tissue, which is called the tunica albuginea. This is where the trouble starts with Peyronie's disease. And this tunica is made of collagen, and it sends pillars into the erectile structure. So when the corpora cavernosa fill with blood and the penis starts to erect, then it gets firm because of this collagenous structure, which is the so-called fibroskeleton. And then I've seen some really nasty injuries. So it's a fracture of the penis, which can happen at the worst. But also there's so much false advice and misleading advice on the internet what to do, and many people or many men they're very obsessed with their penis, so they're trying to enlarge their penis, and there's this technique called jelqing, where you actually have a halfway through erected penis, and then you're just pulling the blood, I don't know if you can see it, from the base to the top while you're at the same time you're contracting your pelvic floor. And this year I've seen some patients who reported to me, well, it popped for some reason. Then the erection broke, and permanently. So I think doing this to a half erect or erect penis is dangerous. I don't recommend it. But for the placid penis, no problem.
So okay, so when you do shockwave
Hmm.
for erectile dysfunction, because I've seen, you know, some studies where they encourage, you know, to actually have the penis fully erect.
Hmm.
So do you do it more in like full erection or more in flaccid
No,
states or
no, I'm doing this in a flaccid state.
okay?
I've seen that too. I think there was a presentation of this at the MSKCC.
Yes, yeah, yeah.
Uh,
SMSD, I've
as
seen it there.
MSD, yes.
Yeah,
Um, yeah, I don't know. We will see where science leads us.
exactly, exactly.
But when we combine erection and pelvic pain, and this is something that I think is very interesting because it defines the outcome of shockwave therapy for erectile dysfunction, is the pelvic floor. I think
Yes,
the pelvic floor is a big confounder in all the studies that you do with shockwaves, because once the pelvic floor is overactive, it always almost has an impact on erectile function.
mm,
And I think maybe this is the reason, while in some patients it's really working, and in
yeah,
some patients it's not. It's the pelvic floor which is the crucial variable here. I
yeah.
found out about this while treating patients with pelvic floor dysfunction, and this was one patient who has pain. And I've never talked to him about erectile dysfunction before. So
Yeah.
one day he says to me, Doctor, is this normal that I can drill my mattress at night with my erection suddenly? And I said, okay, what's happening here? And then I really started to ask all my pelvic floor patients about erections. And it turns out that many of them had erectile problems, which then got better when I treated the pelvic floor. And the only piece of the penis, the part of the penis which is inside this treatment area is the crura, which are inside the body. But I never in neither of those patients did I treat the penile shaft. So it was just the pelvic floor and the crura, and then lots of them suddenly got better erections.
Yeah.
I think this is a very important parameter that is easily overlooked, and I've never seen it in any scientific study on
Yeah.
shockwaves and ED.
I think you're into something because, you know, when we look at from the scientific evidence of the shockwave, how powerful is to stimulate angiogenesis, blood flow, and all of that.
Mhm,
If, you know, EDS, as much as I know, is related to poor blood circulation, then the shockwave is gonna, it must have, you know, constant effect, because that's the
mhm,
metric, that the factor that is missing.
mhm,
But yes, because even in our clinic, we have been doing, you know, ED treatments with shockwave since 2015. And there are cases that, yeah, they see, you know, miracle change. There's cases that nothing
mhm,
happens. And then
mhm.
there was a case where a client who was getting ED treatment, and then he came back and said, it's like, my knee pain is gone. And it's like, we didn't touch his knee, you know. So that's something that it's like, it confirms that it is, you know, from the kinetic
Yeah,
chain aspect, it
yeah.
is like needs related to the pelvic floor stability. So
Mhm.
so the treatment that was done for the ED, you know, it helped the pelvic floor muscles, and then it helped his
Mhm.
knee.
Yeah, that's incredible. What can
Yeah,
happen?
yeah.
I had a thought. Just go on. I catch up. I had a thought that I wanted to tell you, but I don't remember.
Yeah. Whenever it gets there, then
Yeah.
we'll include it. It's all good. So yeah, there is another thing that I just wanted to talk about a little bit about your training, actually, through the
Mhm.
Medical Shockwave Institute. And I hope that this doesn't come any sales here or anything. I don't want to do that, but I just wanted to truly share with practitioners that if you're planning to do men's health treatment with shockwave or pelvic floor treatment, because like I think it's getting there soon. There's gonna be, you know, even female treatment with shockwave, because it's a tool. The pelvic floor is the same. So if we have all those issues in the pelvic floor area, it's getting there. They're gonna use it. I've seen, you know, some practitioners doing those treatments. Just personal experience in the shockwave community, I don't think so. I don't know personally anyone else in the world that teaches or put light in the pelvic health with shockwave than you, Stefan. So it's
Oh, thanks.
I can say this with very much confidence, knowing, you know, the training, how it looks like, and then the support that you provide. And it's something that our platform is so dynamic that if things change, you know, we're gonna update it, we're gonna put it there. So if you're looking, or if you already do shockwave for erectile dysfunction, Peyronie's, pelvic pain syndrome, we have, you know, the training for you available. And Stefan is the human behind it. It's the engine behind it. That it's gonna teach you how to do it properly.
I can just add that I have treated women with
Yes,
shockwaves.
yes.
And the thing is, it works in men. Why shouldn't it work in women, as you said? And there was one episode that was before I was treating shockwaves, pelvic pain with shockwaves. It was one day which was very remarkable, because first I had a man, and he was suffering from chronic non-bacterial prostatitis, and he came for a second or maybe the 30th opinion. He had been to every doctor in the whole world, and he had with him his own examination jelly, which he had pre-warmed, because he told me that any kind of jelly from doctor's offices was so cold that it would immediately cause a backlash in his disease. And he had the typical symptoms. A little later that day, there was a young woman, And that was so strange. She was telling me exactly the same story as this man, the same kind of symptoms. But problem is, women don't have a prostate. So what do we do if they don't have a prostate? So she was being labeled with chronic cystitis. And I thought, that can't be right. So how come she is chronic cystitis and he is chronic prostatitis? That doesn't make sense. So there are women out there who have the same kind of symptoms like men have. We label them chronic prostatitis in men, and in women we just say it's chronic cystitis. So it doesn't make sense. And what I'm doing is I'm giving many of my patients, when I suspect pelvic floor issues, and especially when this is connected to urgency, I give them tamsulosin. Tamsulosin is a selective alpha blocker, and what this does is that it loosens up the bladder neck. So the muscles in the bladder neck get looser, and for some reason, I think this is the mechanism behind this. So if you have a constricted or overactive pelvic floor, and especially in the bladder neck, you get urgency. So I see this in around 30% of my patients, the male patients, that they get really relief from tamsulosin. So I tell them, take this for 3 days. And if you don't have a new life after 3 days, then just don't take it anymore because it's not working. And I use this as a diagnostic tool, because when they respond to tamsulosin, then I really know I'm on the right track here. If they don't respond, it's still not out of the picture, but it confirms my diagnosis. And I remember one woman, I do this in women too. It's off-label. It's a drug that's officially only certified for, licensed for men, but well, you have to talk to your patients. You have to document that you're giving that to them. But it also works in women, so I try this in women too, if it works. And if it's not working after 3 days, so I'm sure it doesn't have any effect. But it also works in women, and you can also do shockwaves in women. So I've seen
Exactly.
results with that
Exactly.
too.
Exactly. Yeah. I actually personally treat lots of C-sections.
Mm-hmm.
This is like completely obviously different topic, but it's related to the pelvic floor,
Mm-hmm.
because after a C-section, the pelvic floor, it's a mess
Yes.
from scar tissues, pulling fascia, lots of dysfunction, and I get actually great results with it, and
Mm-hmm.
that's kind of
I
yeah.
When I started off after my university and when I was a resident, I started off in gynecology. So when I was interested to have a look at this, and I was at C-sections, and I can just tell you, these are big instruments. I've never seen any surgeon use this kind of instruments. So it's big scissors and big knives. In gynecology, everything is big. Like if you go into general surgery or even and also urology, I think you've got to respect the tissues. So we're really dissecting and trying to very gentle, but not in gynecology. It's just and therein you are. So naturally, lots of big wounds which need rehabilitation. And I really think that Shockwaves can do a good job here.
Yes, yeah. I've been actually treating C-sections for over 9 years actually, or
Mm-hmm.
even more than that, and that's been the game changer to chronic lower back pain, neck
Mm-hmm.
pain, to like hip flexor tightness, like all kind of things. It's yeah, it's pretty incredible.
Plus, you have some experience with wounds, right?
Yes, yeah. So
Surgical wounds.
more scars. So I treat
Mm-hmm.
more scars. It's interesting, Stefan, because the possibilities with Shockwave, and this is something that for practitioners that have multidisciplinary, clinics, it's one tool that can be used in many different areas of the practice. Where on pain clinic is more an we focus on pain, but we actually use Shockwave for pain. We use
Mm-hmm.
Shockwave for men's health, and then we use Shockwave for aesthetics. In aesthetics, it's more for graceful aging. We treat, scars like post-surgical scars, stretch marks. Like for stretch marks, it doesn't get rid of it. It doesn't disappear. It doesn't make the scar disappear,
Mhm.
but it makes it look so much better. Like it removes the keloid, and then the healing happens much faster. So
And you remember at the ISMST meeting, they showed us pictures of wounds, of chronic wounds, and they really advised us to do shockwaves after
yes,
surgery, especially in those risk patients with diabetes, where we know that wound healing is going to be compromised or the risk
exactly.
is very high. And I really thought it was amazing pictures. Well, to me,
Honestly,
who's been
they're
surgically
unbelievable. Yes.
trained. I've showed one of those pictures to patients, and they just look at this and say, "Okay," and I said, "No, look at this. This is just amazing." But it's only if you see lots of things happening and wound healing problems, and
Yeah.
that was just amazing. And I'm about to give shockwaves to my patients after surgical procedures. And there's with the Duolith, you have two hand pieces that you can use. I have
Yes,
the
correct.
sepia.
Yeah.
Just to explain, they pretty much look the same. The sepia has a blue ring, and there's a C-actor handpiece has a red ring. Otherwise, they look exactly the same, but the focal point is a little bit different. So it's more narrow to the surface in the C-actor handpiece, so we can treat more on the surface. And this is something that is pretty much usable for scars and for wound healing.
Yeah. See, Stefan, this is something that just like Saturday and Friday, I had two practitioners, contacting me. And they said, "Oh, we need the training." And I asked them, "What kind of device did you got?" And
Mhm.
both of them, they got it, from Amazon.
Mhm.
And I'm kind of going back to that because there is so much, in shockwave technology out there, but then you
Mhm.
must know the basic rules of the shockwave. So anytime when there's a shockwave, it's not the jackhammer. It doesn't
Mhm.
sound like a jackhammer.
Mhm.
It's whether it's, electromagnetic, electrohydraulic, piezoelectric, it's creating shock waves. Like that's the true shockwave. Because unfortunately, I listened to a podcast a few months ago from, a guy, a biohacker that created his own shockwave brand.
Mhm.
And I listen, it's like he's talking, it treats wounds, it treats this, it treats this, it treats this. And then when I look at it, it's a device from uh copy of shock, like radial pressure wave device.
Mhm.
So we have always to remember this, because when it comes to wound healing, you need the special tools. Doesn't matter if even like different applicators have, you must use, or it's preferred, suggested to use the defocal shockwave, where the energy is not as concentrated. So yeah.
Mhm. And I think it's very important to point out that we mentioned this. Now we were talking about our successes, that there are patients where we don't have any success at all.
Yes, exactly.
And I'm always trying to find out which are the ones where I could be most successful. And in the beginning, I was doing these injection tests. You put in, you inject an agent, which is alprostadil here in Europe, and I think it's Trimix in the US. And then you bring about an erection, and you measure the inflow of blood, and you also have a kind of impression on the outflow, because you know that shock waves, they increase blood flow and they increase
Yeah.
vasculature. But I didn't find any correlation between this test and the results of this test to the actual outcome. So I just forgot about it. So
Yeah.
I don't do it anymore this frequently. There's one test that I'm doing. It's just squeezing the penis. I call it the
Yes.
wheat bread penis. Like if you squeeze it, yeah, like fresh loaf of bread, and in North America you can squeeze it to this size,
Yeah.
and it's the same with the penis. If you have a wheat bread penis, ah, it's it's a sign that there's lots of um, structure and lots of tissue that has been lost.
Hmm.
And those don't respond very well. This is pretty much the only thing that I can say. Those don't respond. And we must not forget, it's especially true for ED, but almost for everything in medicine, much of it also is between the ears,
Yes,
and
exactly.
especially in ED.
Yes.
And this is why I'm saying that patients who are younger than 40 years, patients in their 20s, they can have also organic problems, but the number of patients with psychogenic ED is higher than in the older age groups. So this is why I don't see these successes in the younger age groups, because they have other issues that they're dealing with. And
Yes.
commonly, they are diagnosed with something like the venous leakage. Personally, I don't really understand this concept. I know how it works, but I'm not sure why should young men have this. And this is where I'm struggling a bit with this concept. Maybe it's also a matter of psychogenic ED, and psychogenic. It sounds very creepy, but in fact, psychogenic is in most cases that they are very nervous, and the expectations to what is going to happen, the expectation to what they will have to deliver and show off in sexual performance, that's hindering erections. That's
Yes.
as simple as that. Because we, inside every one of us, there's some caveman, and at these times, people were quite simple, and we still have these structures in between us. So, whenever there's a threat, we either fight or run, and you can turn it every way you like. Like running or fighting is not good with an erection. So nature has just killed that function.
Yeah.
And when you're very eager and very nervous and you want to deliver, and then you are fighting or running, so you don't get an erection. And that's the problem. So you can't cure that with shockwaves.
Exactly. Exactly. You know, Stefan, I've learned so much just from the time that I know you, and I thought that I knew a lot, about shock and ED, just going to conferences and stuff. But as I said, you take it to completely next level, and it's more real life stories. It's not just scientific evidence or case studies or everything controlled, because in private practices, you're in private practice, I'm in
Hmm.
private practice, we get paid based on results.
Hmm.
So we have to figure out what is working, what to look for to get to those results, so we can help more people. And we are a business in the end of the day. The moment
It's
that the person pays, it's we are same
mm,
as everybody else, so we have to survive as a business too. So that's why it
yeah.
matters a
And
lot.
I think it's a different kind of research. I'm not writing protocols. I'm not looking for research money,
Yeah.
and I don't have anybody to report to, just me
Yeah.
and my patient. So what I can do, I can react much faster and adapt my strategies much faster than any scientific unit can.
Yes.
So I know what's working right now, but my approach is, okay, I know what's working, but maybe I can make it work better.
Yeah,
So
fine
what do
tuning.
it? Yeah, and this is how I'm changing my patterns. So I know I can rely on my results. But if I add something or change something here, maybe it's getting better without compromising the effects.
Exactly. Exactly. Okay, Stefan, you and me, we can go for hours. So I
Yes.
think we have to end here. Any good thing has an end, but the good thing is that we are available for anybody who wants to be part of our community. So they can just go to iloveshockwave.com, and if they're looking to specialize in men's health, they have Stefan. If they're looking for muscle skeletal condition and graceful aging, on teaching those courses. But I want everybody to know that Stefan has his channel, for patients for people in urology called Channel. So search him
Hmm.
up on YouTube because he's very famous. As to this point, you're like 250,000 subscribers or
Almost
almost.
44.
Okay, so let's get the rest. Let's
I
share
will
and
this year. So
exactly.
it's looking good for this year. So I think I will pass 250K this year.
That's awesome. That's awesome. That's awesome. That's awesome, man. That's awesome.
And I think this is also something that contributes to my journey of wanting to become better, because I get so much input from my viewers, and I really have to work hard to come up with new topics. So I'm not repeating this stuff all of the time. So right
Yes.
now I've counted the other day that I've had over 120 videos about the penis on topics which are not very much related. So I came up with 120 different topics on the penis.
Oh
So,
my God.
so there's a lot to learn about this organ, obviously.
You know, it's like I would never imagine from that size, to pull all those videos. That's awesome. That's awesome. I enjoyed so much. I hope you did, and I hope the
Yes,
audience, did. And then this is not the last one. So, if we were able to pull all those videos, from just the penis, I think from Shockwave we can pull a lot more, right?
yes, we can, and we will. And because
Yes.
what's the good thing about this course is I will exchange videos as I
Yes.
progress. So I will
Yes.
also always update to my standards that I'm using.
And the other thing is, Stefan, that's why when I built this platform, I didn't want it
Hmm.
to be just like, okay, we just want to teach you temporarily. So it's one-time payment, lifetime access, community support, because we truly want to be a hero to the practitioner,
Hmm.
so the practitioner can be a hero to their patients and clients, and this is our impact to the world.
Yeah, and even the other way around. I mean, it could be that some of the practitioners they discover something, so they approach us and say, "Well, I found out
Exactly.
about this. What do you think?"
Exactly.
So we can learn from each
Exactly.
other.
Yes. Yes. Yeah. Okay. Thank you very much again, and let's sign off here, and then we'll go with our life and come back again in the future.
Yeah, thanks for having me. Bye bye.
Thank you. Thank you, Stella. Thank you. Bye bye.